Very good evening. So, welcome to the academic session of the Yashoda Hospitals Group, Department of Emergency Medicine, on the topic for crimson clues for the approach to the hemoptysis. I welcome Dr. Praneeth, senior consultant, Yashoda Hospital, High Tech City, with a decade of experience in the field of emergency medicine, to take over the session and on the crimson clues of hemoptysis.
Thank you, Dr. Bharat. Thanks for your introduction. Let me share my presentation first. I hope you are able to see my screen.
Yes, yes.
Good evening, everyone. Today I'm going to talk about crimson clues, nothing but hemoptysis. So this is it's not a common thing. Hemoptysis is a not common thing, but blood is a common thing which we see in emergency. But in these situations where patient is bleeding, but we don't know from where the patient can be bleeding. So the definition of hemoptysis is expectoration of the blood from the lungs or tracheobronchial tree. And easier way to differentiate, this is not a gold standard or something, but easier way to differentiate between hemoptysis and hematemesis, where we all emergency physicians get confused, is hemoptysis is bright red in color, whereas in hematemesis it will be dark red in color. This is not a hard and fast rule. 80% of the cases it will be like this, but most of the hemoptysis will be associated with cough, whereas hematemesis will also have some GI related symptoms like vomiting, retching. So hemoptysis is something which is related to lungs and bright red color cough, and hematemesis is dark red vomiting and retching. So our topic is hemoptysis. So directly we'll go into the classification of the hemoptysis. Broadly, in our emergency medicine, hemoptysis is classified into minor hemoptysis and major hemoptysis. So minor hemoptysis is a small volume expectoration of blood in a patient. So with the following conditions like no comorbid lung disease or normal stable oxygenation and ventilation, normal vital signs, and no risk factors for continued bleeding. Whereas major hemoptysis is severe hemoptysis where 100 to almost 1000 ml of blood in 24 hours. Definitions can vary with each book, but this is the standard where we see it is more than 100 ml in 24 hours. And along with that, patient can have airway compromise, hypoxia can be there, hemodynamic instability can also be there, and coagulopathy can also be seen in major hemoptysis. And hemoptysis, sorry for the quality of the picture, but I wanted to show the battle camp mnemonic to remember the causes of hemoptysis, that is bronchitis, aspergilloma, tumor, tuberculosis, lung abscess, embolus, coagulopathy, autoimmune disorders, mitral stenosis, and pneumonia. So coming to managing patient with hemoptysis. So while we are managing this patient, what is the biggest challenge? Here, the biggest challenge is it's not just stabilizing the patient. Here, along with stabilizing the patient, we need to simultaneously understand where is the source of the bleeding, and we need to control the source. We need to stabilize the patient and we need to control the source. Even if we stabilize and if we are not able to control the bleeding, again, that patient will eventually deteriorate. So for this, the most important thing is we need to examine two things. One, we need to examine the patient, and also we need to examine the sputum. So while examining the sputum, we will be seeing the quantity and what kind of sputum it is. Is it bright red or clear red? And also, does it contain any other things? And while examining the patient, we will be seeing the nares and posterior pharynx to see for the evidence of epistaxis, which is having like this. And also, we'll auscultate the patient and see whether there are any reduced blood zones in a specified location. This indicates where the blockage, example, if there is decreased air entry in the lower zones, then lower zone of the one side, probably that might be the site where it is bleeding. Occasionally, crackles can also be present, but if crackles are present, that suggests diffuse alveolar hemorrhage, or heart failure. Coming to investigations, once as soon as you have seen the patient, what investigations we can send? We can send electrolytes, renal function tests, complete blood counts, coagulation studies, and urine analysis. And please understand, whenever you have received this patient in emergency, as soon as you have done a blood gas or something, you have done rapid test where you have seen hemoglobin of 12 or 13, don't be reassured that this patient is not bleeding. Usually it takes 3 to 4 hours, or at least in some of the patients, it takes up to 6 hours to come into equilibrium. So even though the patient has blood, patient might be in hemoconcentration and falsely hemoglobin might be elevated. So along with this, we also need to see how the partial pressure of oxygen and carbon dioxide is there. So arterial blood gas analysis we'll be doing, and point of care ultrasound we should be doing, that is lung ultrasound and also echocardiography, to understand how is the contractility and how is the IVC. Do we have to transfuse blood right now? All these decisions we can decide based on that. And doing a quick chest X-ray bedside is going to give us a lot of information. Ideally, where is the bleeding, which side is affected. These gross main things can be done. And also in some cases, we can do differential diagnosis also based on chest X-ray. And CT angiography is the gold standard where we can identify whether it is bleeding or not and where is this bleeding. Coming to initial management. First, as soon as you have taken the patient on the stretcher, please try to make the patient headed up, start oxygen, high flow oxygen to correct hypoxia, and obtain blood samples just like a trauma patient. In a polytrauma patient, how to keep wide bore IV cannula, the two IV cannulas, if required, to run the bloods and also the fluids, and try to maintain hemodynamics, that is MAP more than 65. And if hypotensive, consider blood transfusion over giving fluid bolus. Fluid bolus can be given initially, but it is better to avoid and start blood transfusion. And in case of coagulopathy, please consider reversing agents. Coming to treatment, grossly specific treatment has, first thing is airway control, which I'm not going to teach about the airway control now, but second thing is emergency bronchoscopy. Third thing is definitive bleeding control. Coming to airway control, definitive airway decision should be made at the earliest, because these patients' airway is always threatened. And while we have taken a decision or we are going to intubate this patient, we need to use larger diameter. At least it should be 8 size or more than 8 size ET tube we should be using. The main reason is, if the ET tube size is bigger, we can do a bronchoscopy through the ET tube. If it is smaller, then they need to change the tube before they do bronchoscopy. And once the patient is intubated, place the patient in lateral position so that the affected lung is in a dependent position. This prevents the spilling of blood into the unaffected side. If the bleeding is really uncontrollable, we can try to do endobronchial intubation, that is main bronchus intubation of the unaffected lung. Something like this, where you can see that ET tube has gone into the right main bronchus, where left side of the bronchus is filled with blood. So in similar conditions, we can also use ET tube in the normal position, and we can pass a Fogarty's catheter and try to inflate there, which will act as a tamponade and also seal the bleeding which is inside, so that the other side of the other lung is ventilated. Coming to bronchoscopy, urgent bronchoscopy is needed in massive hemoptysis. This is to identify the origin of bleeding and also to control the bleeding and stabilize the patient. Can be performed in ED itself. We don't have to ship the patient somewhere else. There are two kinds of bronchoscopy, that is flexible and rigid. Flexible bronchoscopy gives better visualization, whereas rigid bronchoscopy gives better intervention. So what textbook suggests is combined rigid and flexible gives very good outcome. After rigid bronchoscopy, a flexible bronchoscope can be passed down the lumen of the rigid bronchoscope for more detailed inspection. And coming to definitive bleeding control, it can be done by bronchial artery embolization, which is done by interventional radiology team, or in case of major hemoptysis, which is caused by artery fistula and all, this can be dealt by cardiothoracic team in CTOT. Bronchial artery embolization is a simple procedure, just like how we have seen angiogram, which will be done left and right in most of the hospitals. Same thing where instead of going into coronary vessels, here they'll be going into bronchial arteries, and there wherever it is bleeding, after seeing the spillage, there this embolization can be done. So this is one of the example where before you can see the left side image where before the embolization, you can see the dark color spillage at the tip. Whereas in the right side, that is after image, if you see, there is no spillage after embolization. And because we are blocking a bronchial artery, the common complications which can occur is transverse myelitis. This is due to spinal cord ischemia, and pulmonary artery infarction from the spread of embolic material beyond its intended site can also happen. And this is my last slide. And pitfalls during managing the patient with hemoptysis. That is, first thing, most of the hemoptysis patients are patients of old tuberculosis. And one more differential diagnosis where we need to think is hemoptysis, which is cyclical. Only once in a month it is coming, after that it is not coming. This can be seen in pulmonary endometriosis. And in individuals with connective tissue diseases or suggestive symptoms such as arthralgia, myalgias, recurrent fevers, or rash may develop vasculitis, and also hemoptysis can be seen. And thank you all for patiently listening to me. And thanks for Yashoda organization and Dr. Tejasvi, Dr. Srinath Kumar, sir, for giving me this opportunity to speak on this forum. Thank you all. Over to you, Dr.
Thank you, Dr. Pranit, for the one on how do we approach for the patients coming to ED with hemoptysis. I'll just brief the session with what you have presented. How does the bleed look when the patient comes to the hospital with hemoptysis, and then you stabilize, and not only stabilizing, determining the source is very important. Send the labs for ABG, hemoglobin, POCUS, chest X-ray, and gold standard of CT angiography. And management, patient, putting the patient in the propped up position, getting IV access, hemodynamic stability, and considering the blood transfusions is very important. Later on, like reversing agents, if there is any coagulopathy we suspected, and the airway management with the larger size tube, and bronchoscopy and bronchial artery embolization for the definitive care. And I request the other spectators, like if you have any doubts, please feel free to ask.
I don't think any questions are there.
Yeah, can we end the session now?
Yeah. Thank you, Dr. Bharat. Thank you, Dr. Tejasvi.